We're going to start with the CPR that Jenny's just mentioned, and we're going to start with child CPR. Remembering your primary survey of your doctor's ABC: danger, response, shout for help, airway, breathing, and if the child isn't breathing, start CPR. So the first thing we're going to do is make sure that we're safe to approach. That's really, really important that you don't become a casualty. Once you've done that and you know it's safe to approach, the next thing we need to do is check for a response. And a way of doing that is to tap the child on the shoulders and shout at them nice and loud to see whether they respond, whether they're conscious or they're unconscious. If the child doesn't respond to us and you're by yourself, it's really important now that you get some help. So we're going to shout for help. If somebody comes to help us, one of our colleagues, we can get them to dial 999 straight away to get the ambulance on its way. Once we've done that, we can then look at the airway. So we want to open the airway. And a simple way of doing that is to place your hand on the forehead, 2 fingers under the point of the chin, and we're going to tilt the head back and lift the chin up. And with the airway in this open position now, we can assess for breathing. The 3 things that we do to assess for breathing is we look, we listen, and we feel. So we're looking for chest movement, we're listening for exhale breath, and we're feeling for that breath on our cheek, and we take 10 seconds to do that. After those 10 seconds, if the child isn't breathing, we need to give them 5 initial rescue breaths. And the way to achieve that is to open the airway with a head tilt chin lift as we did before. This time with index finger and thumb, pinch the nose closed and cover the whole of their mouth with yours to create a seal. We're going to blow in for 1 second, just enough to see the chest rise. Having repeated that 5 times, we now look to see whether that's had any effect on the child. If the child is showing no signs of response to that, what we now need to do is start doing some CPR. And the way to do that with a child is to place the heel of one hand in the lower third of the sternum. And we're going to push down 30 times on the chest at a depth of a third of the depth of the child's chest. And we're going to do that at a rate of 100 to 120 compressions per minute. If you're unable to achieve a third of the depth of the child's chest with one hand, then use 2 if you find it much easier. Once you've given those 30 compressions, we then need to give them 2 rescue breaths, just as we did before. And repeat that now. And we'll continue doing that for 1 minute if you're by yourself. So that's 3 lots of 30 compressions and 2 breaths, and then we will phone for an ambulance. If somebody has already phoned for an ambulance, we'll just continue doing the CPR until help arrives. What I now want to do is move on to looking at infant CPR. So I'm going to swap the mannequins over and look at some of the subtle differences in infant CPR. Again, remembering your priority of care, which is your primary survey of doctor's ABC, making sure that you're safe from danger before you approach. Once you've done that, again, assess for a response by tapping the child on the shoulders and shouting, see if there's a response. And then what we need to do is shout for help if we're by ourselves. Looking again this time to open the airway, what we don't want to do this time is tilt the head quite far back as we would with an older child. What we don't want to do is compromise their airway. So we'll put the child into a neutral position. And the way to achieve that is hand on the forehead, 2 fingers under the bony part of the chin again, and to put them into a neutral position. This time we're going to assess the breathing just as we did before, look, listen and feel, but try and have a look down the abdomen as well, which children tend to use more to affect the breathing. So ear down to the mouth, look, listen and feel for 10 seconds, and if they're not breathing, we need to give them 5 initial rescue breaths again. This time, with the mouth and the nose being in such close proximity, what we're going to do is cover the whole of their mouth and nose with our mouth. So with the airway in the open position, five initial rescue breaths, just as we did before. If the child doesn't respond to those breaths, we now need to do some CPR again. The difference being now is that our chest compressions are going to be with 2 fingers as opposed to 1 hand. So 2 fingers in the lower third of the sternum, and we're going to push down a third of the depth again, and we're going to do that 30 times at a rate of 100 to 120 compressions. 2 breaths. And 30 compressions. And again, we'll repeat that until help arrives if it's already been called for, or if you're by yourself after 1 minute or 3 cycles of 30 to 2. So now we're going to look at choking, and we're going to look at dealing initially with choking in adults and older children over the age of 1. What you've got to remember is that when somebody's choking, there's 2 different types of choking, if you like, a mild and a severe airway obstruction. And to tell the difference between the 2, usually when somebody has a mild airway obstruction, they're able to speak and are also able to breathe, which means obviously they can do something very importantly for themselves, which is to cough. So where a child or an adult has a very good, effective cough, what we want to do is encourage them to continue that, because if anything, that's what's going to clear the obstruction. If a child or an adult is unable to cough, or the cough becomes ineffective, that's when we need to do something for them, and we need to act quite quickly. So the first thing that we're going to do is start by giving 5 back slaps. So supporting the child's chest as they will tend to lean forward, what we're going to do is standing slightly to the back and to the side of the child is with the other hand in between the shoulder blades, we're going to give them up to 5 back slaps, remembering that if the first one works, we don't need to give the other 4. So, if those 5 back slaps are ineffective, what we then need to do is move on and give them 5 abdominal thrusts. And the way to achieve that is to clench the fist, place it over the abdomen and bringing the other arm round, we're going to clench the fist and we're going to pull inwards and upwards to force air out of the lungs and hopefully dislodge whatever's in their upper airway. Repeat that 5 times if it's not effective with the first go, and then if they don't work, we alternate them between back slaps and abdominal thrusts. So 5 back slaps, 5 abdominal thrusts, and we continue to do that whilst the child is conscious. If the child becomes unresponsive, it's now important that we phone 999, get the ambulance on the way, and revert to the CPR skills that we've learnt previously. What we'll look at now is the differences with infant choking. So the first difference with infant choking is that we would not deliver abdominal thrusts. What we would do is instead chest thrusts. Firstly, remember, just as we did before, if the child's able to cough, then we would allow them to continue coughing. If the cough becomes ineffective, just as before, what we would now do is look to give some back slaps. And the way to do that is to place your arm between their legs, supporting the head, and with the head at below the chest level, we're going to give them up to 5 back slaps, using the fingers and the palm of the hand. So up to 5, just as we did before. If those are ineffective, what we now need to give is chest thrusts. So we're going to turn the child over, again with the legs straddling your arm, supporting the head and the head below chest level. Using 2 fingers as we did for chest compressions earlier, we're going to place those on the lower third of the sternum, and instead this time of giving a compression, it's going to be a thrust. So it's sharper and it's a little bit slower. If the child doesn't respond to those 5 chest thrusts, alternate with the back slaps as we did before and chest thrusts whilst they're conscious. And again, if the child does become unresponsive, we would then start CPR and alert the emergency services just as we did previously. So now we're going to look at anaphylaxis, a severe life-threatening allergic reaction, which we really do need to be on the ball with in recognising and treating very, very quickly. Signs and symptoms of anaphylactic shock are things like swelling of the lips, the airway, the eyes, the neck. There may be raised blotches and a rash. Other things are a hoarse voice, which is an indication of an airway obstruction, and possibly wheezy breathing, almost imitating an asthma kind of symptom. The other things are a rapid pulse, and what we want to do is treat this very, very quickly. So the first thing we're going to do, and most importantly, is to dial 999. Don't delay that call to the emergency services. Once you've done that, what we can then do is get the child sat down or lay down preferably. It's most important if we get them lay down for circulation purposes. Raise the legs, and then if they have an auto-injector, such as an EpiPen, what we're going to want to do is administer this very, very quickly. So what we would do is remove the blue safety cap, and then holding the pen in such a way, what we're going to do is, with a stabbing motion, is to inject it into the outer thigh. So swinging the pen into the outer thigh, we're going to hold the pen there for about 10 seconds. Once we've done that, we can release the pen. The drug will have been injected into the leg, and what we're going to want to do is massage again for about 10 seconds. What you'll notice is that the orange tip of the pen has now been released, and that's covered up the needle. Once we get the emergency services on site, we want to let them know that we've administered this drug, and we want to give it to them so that they can take it away for safe disposal. But the important thing is to remember that we need to act quickly, get the emergency service activated, lie the patient down, and administer the drug if they have it. These things will save that child's life, and it's very, very important that we administer them very quickly. So that's been a brief look at some very important first aid messages which I know that most of you have been concerned about. Obviously this can't replace your formal first aid training, but hopefully it's been a useful refresher for you until you attend your next first aid course. The key messages you need to take away from this really are your doctor's ABC, that primary survey of you remaining safe, checking for danger at all times. Check for a response. If the child or the casualty doesn't respond, get some help by shouting. Open their airway, check for breathing, and if they're not breathing, start doing some CPR straight away and alert the emergency services.
When you get this autoinjector from the pharmacy, it will come in a box of 2 and a training autoinjector. Each autoinjector will be in its own carrying case. Do not carry the trainer around with you. You may grab it by mistake during the allergic emergency. The training autoinjector is gray and contains no epinephrine, and that is what I will be using today. The autoinjector that you will want to use during the allergic emergency will be either yellow or green, depending on which strength your doctor has prescribed for you. You will want to remove your autoinjector from its tube-like case. This is a training injector. I don't have a case to show you. Place the autoinjector in the palm of your hand and wrap your hand around it like a fist. Do not put your fingers or thumb or hand on either end of the autoinjector. Place the orange end of the autoinjector near the middle of the outer part of your thigh. Remove the blue safety cap by pulling straight up. If you do not remove the blue cap, the autoinjector will not work. Swing and push the autoinjector firmly on the thigh until you hear a click. The click means the injection has started. You may feel some pressure from the autoinjector pushing back. This is expected because the autoinjector is under pressure. You want to hold it tightly and firmly in place for 3 seconds. 1, 2, 3. The injection is now complete, and you can remove the autoinjector from your thigh. The orange tip will cover the needle. You'll want to massage the injection area for 10 seconds and call 911. Do not try to reuse the autoinjector.